So now we're going to talk about antimicrobial prophylaxis. In certain patient populations, prophylaxis against organisms is certainly warranted. This image shows some of the vegetations on the mitral valve seen in bacterial endocarditis. Part of the penicillin family, such as amoxicillin, is used in endocarditis prophylaxis in susceptible patients who undergo dental procedures. There are very specific guidelines for which patients actually need antibiotic prophylaxis, which we discussed briefly in the system section. Ceftriaxone is prophylactic against gonorrhea. TMP-SMX, or known as Bactrim, is used in patients with recurrent UTIs. Ciprofloxacin or rifampin in children is used for meningococcal infection prophylaxis caused by Neisseria meningitidis, which is seen in this image. Ampicillin is given to pregnant women carrying Group B strep. Erythromycin ointment is used to prevent gonococcal and chlamydial conjunctivitis. This image shows an older patient who was diagnosed with gonococcal conjunctivitis. You can see the conjunctival inflammation. After surgery, cefazolin, which remember doesn't phase you because it is a first-generation cephalosporin, is given to prevent post-surgical Staph aureus infection. Oral penicillin is given in children who have recovered from rheumatic fever to prevent another strep pharyngitis. Finally, penicillin G can prevent syphilis. As we mentioned before, it's important to remember at what CD4 counts an HIV patient is likely to develop an infection. This table, which I'm going to show you here, is to remind you that for HIV patients with CD4 counts less than 200 cells per millimeter cubed, you are going to provide prophylaxis against pneumocystis pneumonia with TMP-SMX, aka Bactrim. Going down in terms of CD4 counts less than 100, patients should receive Bactrim again to cover not only pneumocystis pneumonia but also toxoplasmosis, which now becomes a risk factor at this lower count of CD4. Finally, patients with even a lower CD4 count of less than 50 should also be receiving azithromycin. This is used to prevent MAC or MAC. So these patients will already be receiving Bactrim to cover both PCP and toxoplasmosis, and then you'll be adding azithromycin to cover MAC. Another important consideration in this case is the prevention of mother-to-child transmission of HIV. We're going to come back and talk about this a little bit later, but the key drug is zidovudine, or ZDV, which is also known as AZT. It is a reverse transcriptase inhibitor. Emergence of bacterial resistance to current antibiotics is very much a real problem in clinical settings. In this image, you can see MRSA or methicillin-resistant Staph aureus. Do you remember what you would use to treat MRSA? That's right, you'd use vancomycin as a first-line agent. Do you remember what other antibiotics you'd use to treat MRSA? That's right, I'm so glad you remember. Daptomycin and linezolid, as well as ceftaroline, which is a fifth-generation cephalosporin, are other agents you can use to treat MRSA. Vancomycin-resistant enterococci, or VRE, is something that I've mentioned before. They are a type of Group D streptococci, which are shown in this image. They are treated with linezolid, and also the streptogramins quinupristin or dalfopristin, which both have very broad-spectrum coverage against gram-positive cocci. I know you're ready for another flash quiz. Let's drill in the facts about HIV because they're very important. In patients with HIV, use which antibiotic as soon as CD4 counts drop below 200? What antibiotic are you going to add when the CD4 count drops even lower, and at what CD4 level? Which organisms are you preventing? In patients with HIV, use TMP-SMX, aka Bactrim, as soon as CD4 counts drop below 200. Add azithromycin when the CD4 count drops even lower, at less than 50. So, which organisms are you preventing? Bactrim or TMP-SMX prevents PCP when CD4 counts are less than 200, toxoplasmosis when CD4 counts are less than 100, and azithromycin prevents MAC when CD4 counts are less than 50. Good job! Alright, we're now going to move on to antifungal therapy. Antifungal therapy targets various components of the fungal wall, and I've shown this to you in this map. We're going to go through all of these in a moment. We have agents that are going to target the cell wall, those that form pores in the cell membrane, one that targets nucleic acid synthesis, and two groups that target either ergosterol synthesis or lanosterol synthesis. There is also an antifungal that targets microtubules. Let's go through these now. Let's first talk about amphotericin B, which, as we mentioned, forms membrane pores. The mechanism of action of amphotericin may be remembered by amphotericin tears holes in the fungal membrane. Ergosterol, which is a sterol unique to fungi, is the target of amphotericin B. Cholesterol is the equivalent sterol in human cell membranes. As you can see in this image, the antifungal binds ergosterol and incites the formation of pores that allow leakage of electrolytes. Can you think what are important electrolytes you may want to replenish in the patient taking this antifungal? Well, as a physician, you need to remember to supplement potassium and magnesium in patients who are on amphotericin because the drug can be nephrotoxic and can lead to the loss of these important electrolytes. Amphotericin is also amphoterrible because it has numerous unpleasant side effects, including fever chills, hypertension, nephrotoxicity, arrhythmias, anemia, and IV phlebitis. As such, this drug is typically reserved for only the most serious systemic mycosis caused by such organisms as Cryptococcus, Blastomyces, Coccidioides, Aspergillus, Histoplasma, Candida, and Mucor. The drug may also be used intrathecally, aka into the cerebrospinal fluid, for fungal meningitis. Interestingly for you, amphotericin delivered in a liposomal formulation has much fewer toxic side effects. Moving on to nystatin, which has the same mechanism of action as amphotericin B, is limited to topical use because of its extreme toxicity when used systemically. It is therefore used for local fungal infections. Topical indications include oral candidiasis, also known as thrush, which you can see in this top image. The nystatin is given as a swish and swallow preparation. This lower image shows diaper rash, which is another indication for nystatin. You can also use it in vulvovaginal candidiasis. Next, we'll look at the antifungals that target ergosterol synthesis. The azoles all bear names ending in their drug class, as you can see here. As you can see in this image, azoles work by inhibiting ergosterol synthesis through inhibition of the P450 enzyme that converts lanosterol to ergosterol. Remember the azoles and their effect on cytochrome P450. This is useful to remember for the boards. The azoles are another class of antifungal that is reserved for systemic mycoses. Some of the azoles, such as fluconazole, have the ability to cross the blood-brain barrier, so have utility in combating cryptococcal meningitis in AIDS patients. The azoles are also used to treat all types of candidal infections. Fluconazole is a drug of choice for chronic suppression of cryptococcal meningitis in AIDS patients. Itraconazole is used against Blastomyces, Coccidioides, Histoplasma, and Candida. Clotrimazole and miconazole are used topically. An important side effect, which is quite common to remember, is gynecomastia. Gynecomastia is common with the use of ketoconazole due to the inhibition of testosterone synthesis due to cytochrome P450 inhibition. Liver dysfunction also is related to the mechanism of action of the azoles due to their inhibition of cytochrome P450 enzymes. Fevers and chills are less specific manifestations of azole toxicity, but are variably encountered with use. So time for another flash quiz. What is the effect of the azoles on the cytochrome P450 system? I'm so glad you were listening. They inhibit the P450 system. So, flucytosine. This antifungal is frequently used with amphotericin B in systemic fungal infections, especially cryptococcal meningitis. This image illustrates the mechanism of action of flucytosine. Flucytosine penetrates fungal cells where it is deaminated by fungal cytosine deaminase to form 5-FU, which is fluorouracil. Mammalian cells do not convert it to 5-FU. 5-FU then inhibits thymidylate synthase, thereby preventing thymidine synthesis. This inhibits fungal DNA synthesis. Like other chemotherapeutic agents, toxic side effects include nausea, vomiting, diarrhea, and bone marrow suppression. Bone marrow suppression in particular is worth remembering since it is a very serious and characteristic side effect. Moving on to the group of antifungals known as echinocandins. The use of caspofungin is limited to treating invasive aspergillosis and serious invasive candida infections. This image will help you remember that this medication inhibits cell wall synthesis by inhibiting beta-glucan synthase, therefore beta-glucan synthesis. Next we're looking at lanosterol synthesis. Terbinafine acts on lanosterol synthesis. It inhibits squalene epoxidase, which blocks conversion of squalene to lanosterol. Terbinafine is used to treat dermatophytoses, particularly the onychomycosis, aka nail infections. An onychomycosis looks like the one in this image. It is usually very difficult to treat nail fungal infections. Remember that the toxicity of terbinafine includes abnormal liver function tests, as well as visual disturbances. Next we have griseofulvin, which targets microtubules. It disrupts mitosis by interfering with the microtubule function. This oral, aka PO medication, is used to treat superficial fungal infections by dermatophytes, such as tinea and ringworm. This image shows tinea capitis. The use of griseofulvin is limited due to its teratogenic and carcinogenic potential. It also has other unpleasant side effects, including confusion, headache, and upregulation of cytochrome P450 enzymes. I know you were just waiting for another flash quiz. Let's review the effect of the two antifungals that impact cytochrome P450. What do azoles and griseofulvin do to P450 respectively? You've got it! Azoles inhibit cytochrome P450, while griseofulvin upregulates cytochrome P450. Okay, so now we're going to review the antiprotozoal drugs. I'm going to show you this table which I'll go over, which discusses all the different antiprotozoan therapies. For Plasmodium falciparum, the treatment is either coartem, which is artemether and lumefantrine, or malarone, which is atovaquone with progranil. In uncomplicated Plasmodium ovale or vivax, the treatment is chloroquine if the strain is chloroquine sensitive, plus primaquine. Do you remember why you need primaquine? Well, the primaquine is to kill the dormant liver forms called hypnozoites. In the case of complicated malaria, the treatment is quinidine or artesunate in the US and quinine elsewhere in the world. Malaria prevention requires malarone, which as I said is atovaquone with progranil, or mefloquine. For toxoplasmosis, use pyrimethamine plus sulfadiazine. For trypanosoma brucei, use suramin for the acute blood stage and add millarsoprol for the CNS stage. In Trypanosoma cruzi, use nefertimox. And finally, for leishmaniasis, treat with sodium stibogluconate. We're now going to talk about chloroquine, which we mentioned in the slide before. It is used as a way to treat Plasmodium species other than Plasmodium falciparum. It works by blocking detoxification of heme into hemozoin. This image is given here so that you can see the birefringence of hemozoin, which is viewed with polarized light. Unfortunately, chloroquine can cause nausea and vomiting. And that's actually it for all the antiprotozoal therapies. We'll now talk about antihelminthic therapies. Any questions like these that you get on the boards are actually going to be relatively straightforward, because the point of the question is just to test whether you did cold memorization for these treatments of diseases that are relatively rare in the United States. So this isn't the most high yield, but if you get a question on this and you memorized it, it's likely you'll be able to get it right and score a few more points. So let's go over this. Nematodes such as Enterobius, Ascaris, Strongyloides, and Ancylostoma or Necator are treated with bendazoles. Note that parental pamawate can also be used for Enterobius and the 2 hookworms, but is not used for Ascaris and Strongyloides. How do these drugs function? Well, parental works by paralyzing the helminths by its simultaneous ability to release acetylcholine and block acetylcholinesterase. Mebendazole functions by inhibiting helminth microtubules. I will note that ivermectin is actually the drug of choice for treating strongyloides. Tapeworms such as the adult intestinal worms Taenia solium, Taenia saginata, Diphyllobothrium latum, and the trematodes or flukes, including Schistosoma, Clonorchus, and Paragonemus, are treated with praziquantel. Let me point out a few things. For Taenia solium, praziquantel is generally used except in the case of neurocysticercosis. In that case, you would preferentially use albendazole. For Echinococcus hydatid cysts, you would actually also use albendazole. However, at the end of the day, surgical excision of a hydatid cyst is the only reliable treatment. How does praziquantel work? It works by increasing cell permeability to calcium, causing paralysis. You'll see a pattern with all of these antihelminthic drugs. They all seem to cause paralysis of the worms. Moving along, other roundworms such as Loa and Wucheria are treated with diethylcarbamazine. Dracunculus is treated with prolonged extraction. Onchocerca, which causes river blindness, is treated with ivermectin. Remember that ivermectin is also used to treat strongyloides. Finally, Toxocara is treated with albendazole or mebendazole. So, flash quiz time. Malaria cases are on the rise in the US thanks to globalization and people traveling all over the world. How would you treat different types of malaria? How do you prevent malaria? Great, I'm glad you were paying attention. Plasmodium falciparum is treated with artemether plus lumefantrine, which is named Coartem, or atovaquone plus proguanil, which is known as Malarone. Plasmodium ovale or Plasmodium vivax is treated with chloroquine plus primaquine. Malaria is prevented with Malarone or mefloquine.